Pressures on bloods acting through our different types of blood vessels. So pressure is the force per unit area that is exerted on a blood vessel. We typically measure this in what's called milligrams or millimeters of mercury. And this is how many millimeters you can push up a column of mercury in a tube based on the pressure that we're exerting. So throughout the system we have different amounts of blood pressure. In our arteries we have systolic and diastolic blood pressure. Systolic pressure is the pressure exerted on the blood in the arteries while the ventricles are contracting. So we could say it's the pressure on vessels due to blood pushing on them during ventricular systole. Our diastolic blood pressure is the pressure that blood is exerting on the blood vessels when the ventricles are in diastole. If our diastolic blood pressure dropped to 0 between heartbeats, we'd pass out. We'd lose all our blood pressure. So this is why it's important that our arteries have elastic fibers so that they can bounce back and still exert pressure on the blood while the ventricles are relaxing. If they didn't have that elastin, if all they did was stretch when the ventricles contract, then when the ventricles relax, if they couldn't bounce back, we'd lose all the pressure in the system. So it's really important that our arteries have that elastin so that they can bounce back and still exert some pressure on that blood while the ventricles are relaxing. We can use these two pressures to calculate another pressure called pulse pressure. So if you subtract your diastolic blood pressure from your systolic pressure, we get this third pressure called pulse pressure, and that's the pressure that you feel when you're counting a pulse. And it's important to be able to calculate pulse pressure because we're going to use the calculation of pulse pressure to calculate another type of pressure, our mean arterial pressure. So our mean arterial pressure is the pressure that is kind of giving us a relative idea of what's going on in the system. There are a couple of different equations that we can use for this. This one's a little more complicated. We can also take our diastolic blood pressure and add a third of our pulse pressure. This one's easier to use to calculate, or you can do 2 times your diastolic blood pressure plus your systolic pressure and divide it all by 3. It's a little more complicated. But what our mean arterial pressure is showing us is the average pressure on all of the vessels throughout the system. And what it gives us is an idea of how much the tissues are being perfused. So to be perfused with blood means that you've got blood flowing through your tissues. If you have a high mean arterial pressure, then you're probably having too much perfusion. So our range, I think I have on the next slide, our range is 70 to 110. We have to, in order to be able to get blood through our coronary arteries, our brain, and our kidneys, which are really important organs to have a lot of blood through, you have to have a mean arterial pressure of about 60, a minimum of 60. If you go below that, you're not perfusing your tissues well enough. The normal range is 70 to 110. So this is the better, easier calculation to do, the diastolic blood pressure plus a third of your pulse pressure. And again, if we get higher than 110, then this is going to say that we've got increased perfusion to the tissues, and then it's possible to get swelling, or what's called edema. So this would be increased perfusion that causes edema. Edema is swelling. You can drop down to 60, but if you go below 60, so if you've got a mean arterial pressure of less than 60, you will not have enough blood flowing through your tissues. So that's going to be problematic because then we won't get nutrient and gases to our tissues. So we would say lower than this, you are not sufficiently perfusing tissues. So the blood moving through our arteries is under what we call hydrostatic pressure. Hydrostatic pressure is the pressure of a fluid on a membrane. In this case, the membrane are the arteries. So we could call blood pressure is hydrostatic pressure. And a general definition of hydrostatic pressure is this is the pressure that a fluid exerts on a membrane. So in the case of the body, the fluid is the blood and the membrane is your arteries.
Sorry, you're saying hydrostatic pressure is the pressure that the
Yeah,
fluid...
a general definition of
Okay.
hydrostatic pressure is that it's the pressure that a fluid exerts on a membrane. In the case of the body, our blood pressure is our hydrostatic pressure, and the fluid is blood, and the membrane are the blood vessel. So that really strong contraction of the ventricles is what's moving our blood through our arteries. Most of that hydrostatic pressure, or most of that blood pressure gets dispersed when we hit the capillary bed. So on the arterial side of the capillary bed, we've got about 35 millimeters of mercury pushing the fluid out. And that's what's going to give us bulk flow on the arterial side. But by the time that we get back to the venous side, we drop that to only about 17 millimeters of mercury. So if you look in the veins that are returning, the hydrostatic pressure in venous blood is only about 15 millimeters of mercury. And when you get back to the right atrium, it's 0. So the blood moving through veins is under different pressures. So let's look at that. There are 3 pressures exerting force on venous blood. First, what we call the skeletal muscle pump. And if you remember, our veins have valves in their tunica intima. Those valves are supported and strengthened by collagen and elastin fibers, but they're simple squamous epithelial tissue that prevent the backflow of blood from one valve segment to the next. So what happens is as we're moving around and exerting or contracting our skeletal muscles, the skeletal muscles will push on a vein and push the blood up from one valve segment to the next. So we call this the skeletal muscle pump, and we could say that the contraction of our skeletal muscles moves venous blood from one valve segment to the next. So you'll contract and the blood will move to the next valve segment, and then you contract again, it moves up and keeps moving up from one segment to the next. This is going to be important for how we return the blood from our limbs. The way that we return blood in the thorax is through what's called the respiratory pump. So as the muscles of respiration contract and relax, that movement will cause movement of venous blood from one valve section to the next in veins in the thorax. So we can say contraction and relaxation of your muscles of respiration moves blood from one valve segment to the next in the thorax. Last force that's acting on blood in the system on a day-to-day, moment-to-moment basis is gravity, which returns venous blood from the head. Under fight or flight or emergency situations, when you're activating the sympathetic nervous system, it is possible to do some venoconstriction, which can help. But again, that's not a moment-to-moment basis, it's when we're activating the fight or flight response. So I'll just kind of put that as a little side note, that we can do venoconstriction, which is squeezing or that skeletal or the smooth muscle in your tunica media, squeezing the veins. It happens to a much lesser degree in veins than arteries because they've got a very thick tunica media, but it's possible. So we can say venoconstriction returns extra blood to the heart in times of sympathetic nervous system activation when we need to get more blood flow going. That'll give us a greater venous return and greater cardiac output. So venoconstriction is due to sympathetic nervous system activation. And will increase venous return to the heart. If we increase venous return, then we can increase cardiac output so that we have more blood flow available to get out of this emergency situation. All right, so as far as our regulation of blood pressure and blood flow goes, we've got different areas in the brain that are going to be responsible for helping with our regulating our blood pressure. By our cardiovascular center has the cardioacceleratory center, our cardioinhibitory center, and the vasomotor center. The vasomotor center is going to be able to alter the diameter of our blood vessels, and so if you are constricting, then you're increasing the resistance on the blood flowing through there, so we would increase pressure. If we are dilating, then we are decreasing the resistance, so we increase pressure. So our vasomotor center can have an effect there. As far as this other side is talking about a lot of reflexes that we're not going to go over. If you're going to go into cardiac nursing, a specialty, if you're going into cardiophysiology, then definitely read over this chapter in the book, or these parts of the chapter, because this is talking about our baroreceptors, which are activating pressure reflexes. We also have chemoreceptors that are going to activate reflexes, and I'm not going to test you on that, but like I said, if you're going into cardiac physiology, you're going to want to look at that in more detail. So the last thing that we'll talk about, the part of blood pressure regulation that I just want you to be aware of and that I will test you on because we've already talked about it, is the renin-angiotensin system. Again, the renin-angiotensin system is activated when the kidneys sense a drop in blood pressure. They're going to respond by releasing renins. The liver is always producing renin substrate. So it's always producing renin substrate and letting it out into the blood, so that as soon as renin enters the system, the two can combine and form angiotensin 1. Renin substrate is also called angiotensinogen. So we add these together and we get angiotensin 1. Angiotensin 1 travels to the lungs. Oh, first it hits the heart. Now that we know more about our pulmonary circuit, angiotensin 1 is found in high concentration in venous blood. So it returns to the heart and will be pumped through the pulmonary circuit. So when it hits the heart, it's coming in the right atrium, going through our right ventricle, and out to our lungs to hit the pulmonary circuit. There it'll meet angiotensin converting enzyme. That name is telling you exactly what the enzyme is doing. It's converting angiotensin 1 to angiotensin 2. So we'll get our Ang1 and convert it to Ang2. And angiotensin 2 really helps. It's a very potent increaser of blood pressure because it's going to act in several ways to increase blood volume. And since it's a vasoconstrictor, it will constrict all of our arteries that it hits and increase the resistance then of those arteries. So as far as the activities of angiotensin 2, it's going to stimulate the hypothalamus to release antidiuretic hormone, and it's going to stimulate dipsogenesis, which is thirst. So if you drink more water, then that's going to increase your blood volume, which will help to increase your blood pressure. Antidiuretic hormone is going to come down and stimulate our kidneys to uptake water, specifically by increasing aquaporin production. We'll talk more about aquaporins when we get to the urinary system, but we'll stimulate water uptake, which is going to increase our blood volume. Angiotensin 2 also stimulates the zona glomerulosa of our adrenal gland to release aldosterone. Aldosterone stimulates the kidneys to uptake sodium, and with sodium goes water. So now we've increased blood volume by 3 different mechanisms: by making you drink, by increasing aquaporins in the kidneys, and by increasing sodium reuptake, and sodium is passively followed by water. So we increase blood volume. And then, because it's also, angiotensin 2 is also a vasoconstrictor, it's going to it's going to constrict on all those vessels, and that's going to increase the resistance. So now all of this extra blood is pushing on vessels that are smaller, and we increase our blood pressure. If we activate the sympathetic nervous system and release norepinephrine and epinephrine, then what will be the effect on blood vessels or blood flow in the system? And norepinephrine and epinephrine have different effects on different blood vessels that have different types of receptors. So most vessels in the body have what are called alpha receptors. So norepinephrine and epinephrine are going to be able to activate two types of what are called adrenergic receptors. So they activate adrenergic receptors. Adrenergic because this is referring to the adrenal gland, and the adrenal medulla is releasing our norepinephrine and epinephrine. So we've got alpha and beta adrenergic receptors. Most of our blood vessels have alpha adrenergic receptors, and so when norepinephrine and epinephrine are in the system, most of our blood vessels will constrict. So this is going to stimulate vasoconstriction in most places in the body. In some areas, namely our coronary blood vessels and our skeletal muscles, have beta receptors. So coronary vessels and skeletal muscles have beta adrenergic receptors, and when norepinephrine and epinephrine bind to beta adrenergic receptors, they dilate. So this will stimulate vasodilation. Why do you think we would want to vasodilate these two areas?
Increase blood flow and help with skeletal power.
Right, so if we're in a fight or flight situation, we want to increase blood flow to our skeletal muscles so that we have more blood and can run or fight or whatever we got to do. And then we want to increase blood flow to our coronary vessels so that we can make sure that our heart has enough blood so that it can pump faster. So we've activated our sympathetic nervous system, we're increasing rate and force of contraction, so we need to make sure that the heart has blood so that it can do that.